Good morning. First of all, I'd like to thank all of you who invited me to present at this prestigious conference. I'm Bassam Hennawy from Ain Shams University, Cairo, Egypt. Today's presentation will be about a case of bifurcation left main standing, and we'll show what's the best technique in this case. At least our decision was what. Our patient, a 50-year-old female patient, housewife. She's hypertensive for 7 years and compliant on her treatment, and she had the previous PCI to LAD and CIRC with drug-eluting stents 4 years ago. She was presented by effort angina CCS class 2 of 6-month duration that was not responding to anti-ischemic medications. By examination, the patient was oriented to time, place, and person. Heart rate was 80 beats per minute. And blood pressure was good, 135/85, and respiratory rate 15 per minute. Chest examination with normal vesicular breathing, and the apical S4 was heard on cardiac examination. Her EKG with normal sinus rhythm, and the echocardiography showed mild LV systolic dysfunction by modified Simpson's method, 45%. And hypokinetic mid anterior wall and apical segments, mild mitral regurgitation, and normal right side. She was planned to undergo coronary angiography. We'll show the films together. As we see, the previously deployed stents were good at the LAD and the CIRC. Probably their ostial lesions will be shown better in consequent views. The ostial LAD appears significant. Left circumflex, less significant ostial lesion than the LAD. The rest of the LAD was normal, and the RCA was normal as well. So we were stuck at this question: the best option for the stenting in this patient, is it provisional stenting or two-stent technique? And that was the most important question in this case. After reviewing the angiography, we decided to do provisional stenting, to stent the left main LAD at first, and we are putting a guide wire in the CIRC as well. And if we needed to do a second stent, we'll do it. These are the guide wires. First, we stented the left main LAD with drug-eluting stent. It passed smoothly without any problems. Okay, and after deploying the stent in the left main LAD, we thought that the ostial CIRC was more compromised, and it required another stent because it appears more significant right here after deploying the LAD stent. So we decided to complete the procedure as a tap technique. We flared the ostium of the LAD stent. And then we passed the balloon to dilate the ostium of the CIRC and the struts of the stent. Then we put in the second stent. After optimizing it, we deployed it, and this result was good, and was only remaining the step of kissing balloons. We first dilated this stent, the CIRC, and then we tried to pass another balloon to do the kissing balloons, but it didn't pass smoothly. After passing it, we slided it over the second balloon so we can introduce it to the LAD stent. Then we did the kissing balloon technique to ensure the patency of both ostia, and this is the final result. And the patient with follow-up remained uneventful with no chest pain, and was showed the good results over 1 year till now. I think the best take-home message from this case that the decision of bifurcation stenting, especially at the left main, is the most important step. The techniques are not so difficult in the absence of complications, but the decision was more important. Another option here was to do a DK crush stenting from the start. But we thought that the provisional stenting will be better. If the circ ostium wasn't much affected, we could stop at the LED stent, but it required another one. So we proceeded to the TAP technique. Thank you.
Thank you, Bassam, for a nice presentation. Couple questions for you. Did you have a heart team approach to the patient? Was bypass surgery entertained, or is it common in your practice to do stenting for left main disease?
We have the heart team approach for sure, but this patient, mostly the two factors led us to do stenting. First of all, the syntax score was not too much, so he was amenable for stenting. The second point that we discussed the two options with the patient, and he refused CABG. So we proceeded to the stenting as a ad hoc technique.
Great. Just a couple comments, and I'll open up the question and see if Dr. Sandoval has a question. I would have maybe approached the case a little differently. So nice results and technique, but a couple things is that you decided to do provisional stenting, which is very reasonable in this case, where you'd stent the LAD into the left main. And I'm glad that you extended the stent further back in the left main to allow you to do bifurcation work with the circ. That's the right thing to do. But from a provisional standpoint, what I would do is, first I would balloon the ostium of the circumflex, kiss it with the LAD, because you may end up with that result and be happy with it without any big compromise in the circumflex, and you'd avoid putting another stent in there. Did you guys IVUS this case?
No, unfortunately we didn't have it.
All right. In general, if IVUS is available, you should always do IVUS for adequate sizing. And
that's right.
Thank you.
You're welcome.
Yeah, it's actually great result. So one other approach that I would consider to do, especially that ostial circ, you didn't know is it significant or not to begin with, would be just to actually FFR it before you proceed with your stenting. And remember, because it's ostial disease, you have to equalize in aorta and then pass the wire, pass the lesion in. Because if your ostial circumflex had a really positive FFR, like let's say 0.7, 0.72, and I've been surprised so many times either way with ostial disease, then definitely that would have different implications for you. Either you would probably think about more maybe bypassing, since it's a failed stent. Now you have a true bifurcation, basically disease, or go upfront with DK crush rather than just provisional. So I think probably I would add FFR to your approach.
Yeah, if it was available, that's a good choice, but we didn't have it as well, unfortunately. Yeah.
Do you want to answer?
I think the anatomy was pretty reasonable for a TAP. I think minimum stent protrusion and the kissing balloon. I actually think that was a very reasonable approach to rescue that. And I think if you have TIMI3 flow and you use physiology and the IFR are reasonable, you can always just do either leave it or do a balloon angioplasty to have less metal in there. But I think that's also a very nice result, of course, at the end.
Yes, of course.